Good morning or good afternoon. My name is Art Slutsky from Toronto, and today I'm going to be talking about ACE2, angiotensin converting enzyme 2, as a possible therapeutic for COVID-19. I'd like to start first with a conflict of interest disclosure. One of them is actually quite important. I consult for Apeiron. This is the company that makes human recombinant ACE2. What I'd like to do over the next 12 to 15 minutes is review COVID-19 only in one slide, describe the importance of ACE2, and there's two real factors that are important, two pathways. One is the RAS pathway, and the second is that this is an entry point for SARS coronavirus 2. And I think this is the major message of my talk, these two mechanisms by which ACE2 might be important. I'll talk about the implications for pathogenesis of COVID-19, and implications for therapy, and then conclude. So COVID-19, as you all know, is a complex disease. It has multiple manifestations. People can be infected and have no symptoms at all, or it can range up to very severe multi-organ involvement. Involvement originally was thought to be largely in the lung. It's called COVID pneumonia. But over the last few months, we've learned that it can affect many organs, and in fact, almost any organ: the heart, the kidney, brain, vascular system, coagulation system. It's a very complex disease. As you all know, this is on the left, the coronavirus with the spike protein, and those spike proteins actually are an important feature of the virus. And as I said, what I'm going to talk to you today about is two roles of ACE2. First, as a mechanism to aggravate lung injury, and that is via the renin-angiotensin system. And the second is that ACE2 is the receptor for the SARS coronavirus, which lets it get into cells and then causes cells to be infected. The renin-angiotensin system has been discovered and is still being discovered over the last century. Renin first identified in 1898. Interestingly, ACE2, which I'm talking about, was only identified about 20 years ago, and the impact of ACE2 in terms of the cardiovascular system and other systems has occurred since that time. Here is just a schematic of the renin-angiotensin system, which I'm sure you're all familiar with. If you look at the left-hand side, angiotensinogen, the renin turns that into Ang1, and ACE then into Ang2. This side on the left has I would call it negative effects. It's largely pro-inflammatory. It causes vasoconstriction. It's pro-fibrotic. There are a number of factors that they're important in homeostasis, but when they're overdone, can lead to injury. ACE2, as you can see, is a key mediator in the center. Here it is in red. You can see ACE2 here and ACE2 here. It converts Ang1 to Ang1 to 9, as well as Ang2 to Ang1 to 7. And these then lead to AT1 to 7, which it has anti-inflammatory properties, vasodilation, antifibrotic properties. I would say the good side of this renin-angiotensin system in the context which we're speaking. So the key here is that ACE2, as you can see, is a central factor in this schema, and it's complex because it acts in a couple of locations in this. So why might ACE2 be important? That's what I'd like to spend the rest of the time on. First of all, this is taken from a paper we published in Nature about 15 years ago, showing that ACE2 is a critical factor that can lead to improvement if you give recombinant ACE2 or worsening of acid-induced injury. Here in figure A is the change in elastance on the y-axis. Higher levels mean more injury, lower compliance, and the time is on the x-axis. And you can see that in ACE2 knockout mice, the wild type models, you can see that there's an increase in injury after acid aspiration, which is much made worse in animals that have ACE2 knockout. In other words, ACE2 is protective. And you can see that as well in terms of oxygenation and with dry ratio. The ACE2 knockout mouse have worse oxygenation and higher wet to dry rate ratio. So clearly showing that ACE2 is a critical factor. A really important part is that recombinant ACE2 can reduce this lung injury. So these are animals given recombinant ACE2. And you can see that in the same model, you can see that the weight to dry weight ratio is significantly lower than the vehicle or the mutant recombinant ACE2. And you can also see here on the right in terms of changes in elastin, the wild type mice with recombinant ACE2 have lower injury than the wild type mice without recombinant ACE2. So ACE2 as a factor that can be a chemical that we use to improve. Around the same time, in 15, 17 years ago, Lee and colleagues showed that angiotensin converting enzyme 2 is a functional receptor for the SARS coronavirus. This is very, very important for what I'm going to be talking about. So that's how the virus enters, SARS coronavirus enters cells via ACE2. We also showed in another paper a number of years ago with Joseph Penninger as the principal investigator that ACE2 is the essential SARS coronavirus receptor in vivo as well as in vitro. And here again, you can see the same axes, percent change in elastins on the y-axis, time on the x-axis, and you can see that the acid control has an increase in injury over time. If you add spike protein from the SARS virus, you can have, there's a worsening of injury. And importantly, you can see that the ACE2 count and the ACE2 control with the spike have the same degree of injury. So the spike protein is important, but it interacts via the ACE2 receptor to cause injury. What about now SARS coronavirus 2? Well, a very nice study and a number of studies over the last 6 months have shown, this is a study by Hoffman and Cell, have shown that the SARS coronavirus 2 is also the receptor that, is the virus that's important in COVID-19, enters cells using ACE2 and using as a protein primer TMPRSS S2, which is a serine protease. So this TMPRSS S2 acts on the spike and through the receptor ACE2 to get into cells. What does that mean? This is just a schematic. So here we have the SARS coronavirus, which enters the cells via the ACE2 receptor, shown here. TMPRSS is not shown, but is important in terms of priming of the spike. Then the virus then fuses with the cell membrane, releases viral RNA internally. This actually then hijacks the cell. So here's the key feature of viruses, and that virus uses the machinery of the cell to produce more virus and more viral proteins. That proceeds. The assembly of new copies occurs in the cell, and then that's how the infection spreads widely due to this coronavirus. So key feature here is you can see if we could block this interaction with ACE2 at the very beginning, that clearly would stop this whole pathway. So what are the clinical implications? Well, first of all, we explain many of the clinical observations we've seen in patients with COVID-19. And secondly, ACE2 is a very rational therapeutic agent to treat COVID-19, given the mechanisms I just talked about, because it can mitigate injury, but it can also bind to the SARS coronavirus and stop it from spreading. The key feature here is that the ACE2 is found in many cells. Tissue distribution of ACE2, and you can see it's in multiple organs, and it's also in other organs. It's in the vasculature. So being in the vasculature, is you can imagine it's virtually access to any organ, including these and the skin. So how might this explain what's going on? Well, nasal ACE2 expression could explain how people get the coronavirus, can get COVID-19. As you know, they inhale, the virus latches onto the ACE2 cells in the nose and then spreads from there. Interestingly as well, it might explain the difference in severity and in the incidence of COVID-19 in patients of different ages. This ACE2 expression is a function of age, less than 10 years up to greater than 25, and you can see that there's an increase in nasal gene expression of ACE2. In terms of the kidney, this is a complicated slide. I just want to show you
There's multiple mechanisms by which kidney injury can occur. And in fact, this is a model for injury of any organ system. But one key feature is that the ACE2 is found on podocytes, and that can lead to renal dysfunction when the virus latches on and enters cells there. In terms of the lung, which is a critical manifestation of COVID-19, the important feature is that the major cell type in the lung that has ACE2 is the type 2 alveolar cell. And if the coronavirus enters those cells and destroys those are the cells that produce surfactant. So you can imagine how that could lead to lung injury, pneumonia, and then potentially death. In the hematological system or the endothelium, SARS coronavirus again can cause problems leading to increased inflammation, cytokine release, which can affect many features related to coagulation. And as we know now, thrombosis throughout multiple organs is a not uncommon feature of COVID-19. It can also possibly explain the sex differences in COVID-19 incidence and mortality. About the relationship is there's about 60% of men and 40% of women who have COVID-19, and that might be explained by the ACE2 receptor. ACE2, men appear, as I said, more vulnerable, and the ACE gene is on the XX chromosome. What about therapeutic potential of ACE2, which is obviously of critical importance? Well, we published this paper a number of months ago in intensive care medicine, and showing, if you look at the left, this is the injury, this is ACE2 in terms of injury, which I showed you data before. If we look at the impact of SARS coronavirus spike leading to then infection of cells, you can imagine how a therapeutic agent that addresses this would be potentially useful. What does that look like? Schematically, it looks like this. We have soluble ACE2, which could bind to the virus, stopping it from interacting with ACE2 on the cells, and that leads to essentially no disease. So essentially, this acts as the ACE2, soluble ACE2 acts as a decoy for the virus. It attaches to the soluble ACE2 rather than interacting with the cell-bound ACE2, which enters the cells, and that actually, when it enters the cells, it as well gets rid of the ACE2 that's on the surface. We looked at this. This is a publication in Cell, again, with Joseph Penninger. This is kidney organoids. On the x-axis here is the increasing doses of soluble ACE2, and on the y-axis is the fold change in infection. And you can see that with increasing doses, there's a dose response curve with orders of magnitude lower infection with animals, with organoids rather, treated with human recombinant ACE2. There's actually now a clinical trial that's ongoing. Peron is a company that's in Vienna, Austria, that is running this trial, and it's enrolling patients with severe COVID-19, but patients who are not intubated as yet. The primary endpoint is need for ventilation and invasive mechanical ventilation or death. And the trial is powered for 200 patients, 100 in each group. This is a randomized, blinded, controlled study. In conclusion, then, there's very strong data that ACE2 is very important and plays a key role in COVID-19. And that's via two mechanisms, via the RAS pathway that I talked about in terms of potentially mitigating injury in the lung and elsewhere. And secondly, as a decoy molecule that can interact early on and bind to SARS coronavirus 2 to prevent it from entering cells. This molecule, the ACE2 receptor, may explain many of the manifestations of COVID-19, since we know that the ACE2 receptor is on many cells, largely epithelial cells in the body, including the nose, the lungs, the heart, the kidney, and many other organs. Finally, there is a current ongoing trial of human recombinant soluble ACE2 in patients with severe COVID-19. It's ongoing. Hopefully, we'll have answers from this trial in 2020. Certainly looks like that will be the case. And hopefully this will help us with this scourge of this terrible disease that's affected the entire world. Thank you very much. It's been a pleasure to give this talk.